me here. So Epiphora is a very common complaint we all ophthalmologists face in our day-to-day OPD. So we all know the structure of lacrimal system, and abnormality anywhere can cause epiphora. Broadly, tearing is divided into oversecretion, that is known as lacrimation, or impaired drainage, known as epiphora. But in practice, we see a combination of these factors. It can be either due to ocular inflammation or ocular surface disease, which can cause reflex tearing, or aberrant innervation of seventh nerve, which can trigger watering while chewing, as we see in crocodiles. And another entity is hypersecretory syndrome, which is very rare. Tearing due to impaired drainage. It can be due to obstruction or malposition of the structures or lacrimal pump failure. In such cases, we can see pooling of tears at the medial canthus. So some useful tips in the history taking. If it is unilateral, the cause is more towards obstruction. Bilateral, either reflex tearing or malposition of the structures. Association to exposure to noxious stimuli, again reflex. Constant, more towards obstruction. Intermittent, more towards reflex tearing. And also make a note of tears, like whether it is clear, purulent or blood stained, as in you see in sac tumors. Associated pain and visual symptoms, more towards reflex tearing. Past history, ask for congenital stenosis, history of probing, trauma, surgeries, medications including glaucoma medications, topical chemotherapeutic agents, systemic diseases, radiotherapy for periocular malignancies and all. Examination. Most of us will not miss all these common conditions, but there are some rare things to note. So this patient came with a history of watering, and there is a mild lid retraction, upper lid retraction in his left eye. So when I asked to close his eye, he has a facial palsy, long-standing facial nerve palsy we might miss. Look for evidence of trauma like scars, nasal deviation, hypertelorism, etc. And swelling at the medial, tenderness at the medial canthal area. If it is below the insertion of the medial canthal tendon, it is from the sac. In first case, it is a lacrimal abscess, and in second one, it is a sac tumor, a firm and a fungating mass. And sometimes there will be canaliculus, fistulous communication between canaliculus and the skin. And ocular surface diseases like pemphigus, Stevens-Johnson syndrome, dry eye, coloboma, exophthalmos, all can cause watering. So this patient came with a history of watering after a history of infection with varicella 6 months back. So syringing was patent in this girl. So while closing the eye, you can notice a stricture, a coloboma, that was causing a epithelial defect, and that was a cause of watering. And always evert the upper lid and see for the signs of allergic conjunctivitis, any foreign body, and corneal staining also. So early morning watering with foreign body sensation while awakening from the sleep could be a recurrent corneal erosion. Floppy eyelid syndrome, here the upper eyelid is abnormally lax, thin and easily evertable, causing chronic papilloconjunctivitis, and this can cause eyelid imbrication syndrome, that is upper lid overrides the lower lid and the lashes can touch the cornea. Malposition, punctal eversion or frank ectropion or centurion syndrome. Here what happens is the nose will be prominent and the anterior canthal, anterior insertion of the medial canthal tendon, anterior limb. So the punctum will not be in close opposition with the globe. Syringing will be patent in these cases, and the patient can have watering. Failure of the lacrimal pump. Patients with poor orbicularis tone, as in facial nerve palsy, or in old age, or in patients with neurodegenerative diseases like Parkinsonism and all, orbicularis tone you have to see that can cause lacrimal pump failure. So make a note of frequency of the blink and completeness of the blink. Examination of puncta, so many things to see. Punctal stenosis, pouting punctum as in canaliculus, or any caruncular mass or even conjunctiva obstructing the punctal orifice. Canalicular obstruction, canaliculitis, scarring, stenosis of the canaliculus or any foreign bodies, migratal punctal plugs. And pressure over the lacrimal sac, it can sometimes show regurgitation of pus, known as Ropla's sign. Tearing in a child, most commonly seen is congenital nasolacrimal duct obstruction. Other causes are membranous obstruction of the punctum, atresia or total agenesis of the punctum or canaliculus, conjunctivitis, corneal conditions, and eyelid abnormalities. And always rule out congenital glaucoma. Investigations, rule out glaucoma, dry eye with appropriate investigations. And tests for lacrimal system is divided into anatomical and functional. So if the syringing is not patent, you can do probing, and if it is a hard stop, that means there is no canalicular obstruction, you are directly touching the medial wall of the sac. Soft stop, that means there is a canalicular obstruction. Fluorescent dye disappearance test is very useful in children who are not cooperative for probing and syringing. That is, instill fluorescent dye and examine the child after 5 minutes. Even after 5 minutes, if you see the persistence of dye, that means epiphora, watering is due to obstruction. Otherwise, it is hypersecretion. If the syringing is free, still the patient has watering, John's test is helpful. Here what we do is instill fluorescent dye into the conjunctiva, and with a moistened cotton tip, you see whether you can retrieve the staining. If it is positive, that means it is watering is due to hypersecretion. Negative, 2 occasions it can cause. One is partial obstruction of the nasolacrimal duct or canalicular block. Then do syringing. So whatever dye, if it has reached the sac, it will come down and moisten, stain the bud if there is partial NLD obstruction. If the dye has not reached the sac, then the syringe, there won't be staining. So if it is negative, that means it is either upper canalicular obstruction or lacrimal pump failure. A nasal endoscopy is useful to rule out any nasal masses like polyps or scars or nasal deviation and all. This patient came with a history of watering, occasional watering with blood-stained discharge, and there was a soft mass here. So on nasal endoscopy, we could see rhinosporodial mass in his inferior meatus. Dacryocystography and scintillography, these are imaging techniques. First one provides anatomical information. So here we are inserting a catheter and injecting the dye into the lacrimal system, and taking radiographs. If it fails to reach the inferior meatus, that means there is an obstruction. Scintillography is in more physiological conditions. Here, radio-labeled tears are observed through a gamma camera and see whether it is coming to the inferior meatus. CT scan for bony abnormalities, craniofacial abnormalities, fractures, sinus or nasal diseases. Dacryoendoscopy is a newer advance. Here, probing system is equipped with a fiber optic viewing system, and you can directly view the site of obstruction, and it is less traumatic. To sum up, with proper history and appropriate investigations, you can come up with a diagnosis in most of the cases. Thank you.